So again, if you're one of those people, right, who you take 200, you don't feel good, you don't feel right, you get down to 80 milligrams, and all of a sudden you're like, this is my sweet spot, right? Because this is where I feel good. I don't have the adverse side effects. Well, you're missing out on part of the anabolism I was just talking about, right? You're not feeling your optimal because people just don't feel they're optimal at that level. So what you can do in that case, instead of find out where you do best on testosterone, and then just add that in Nandrolone. Right. So now you're doing good on 80 milligrams of testosterone. Well, throw on 80 milligrams of Nandrolone. You'll also have that the added anabolism from the Nandrolone, which, increases, which further resolves symptoms of hypogonadism and gives you all the effects that I just talked about without any adverse side effects. And this is another case where we'd use that when somebody's just not doing well on any more than 100 milligrams or 80 milligrams of testosterone. Let's add Nandrolone or Oxandrolone, which we can talk about next. And Oxandrolone is another one.
Hey guys, welcome back to the Danny Bossa podcast. I am joined once again with Ryan Root from hormonesforme.com. I had Ryan on the channel a little while back. We did two videos, one of them in regards to his story of being the largest convicted steroid dealer in U.S. history. So the story of him way back in the day, his roots, if you will, in this type of community and the empire that he built. It's a very, very, very interesting story. I'll put a little link to it to those of you who haven't checked it out. As well as his story of redemption. We called it Doctors versus Bodybuilders. Which is basically this discussion about how the bodybuilding community is light years ahead of the medical community when it comes to like health and fitness and that type of thing, just from the sheer amount of different compounds that the bodybuilding community has experimented with and that the medical community, just outright frowns upon. So Ryan, we've talked a lot offline about how you are implementing through your TRT clinic the ability to use things that are not typically prescribed at other clinics, such as Nandrolone, Oxandrolone, Stanozolol, also known as Winstrol. I know there's Methenolone, which is primo that no clinics use, but we can touch on the benefits of that one as well. Potentially even growth hormone or secretagogues. So what is the main reason that you use these compounds, and why do we have this stigma in regards to things that typically make us look better, feel better, increase muscle mass, decrease fat mass, potentially mitigate symptoms on TRT? So why is this occurring that the medical community just doesn't want anything to do with these things?
Yeah, thank you, Danny. There's been, since the testosterone was created, I don't know, probably even the 60s, 70s, and 80s, there's been it has embarked on a path towards stigma and dogma. This was created through some of the first reasons where the Olympic Committee banned the use of steroids, then professional sports, basketball, football, all professional sports started, slowly banning these substances, Major League Baseball. And then in 1990, the Steroid Control Act, made these Schedule III controlled substances, further challenging the public perception of these compounds, making them more stigmatized. So, therefore it's kind of been about optics, right? And we can compare this to the story of marijuana, right? If we remember the 1950s reefer madness, people were actually educated that marijuana would make you crazy. You could die from it. And if you smoked marijuana, you would go to insane asylum. You would be insane, right? So, and it took us like 50 or 60 years to really start to finally debunk this stigma. And now people realize that, okay, marijuana is not that dangerous, and actually it's pretty helpful to a lot of people, right? So now, takes a long time for these stigmas to dematerialize. And this is exactly what's happened with, it's a similar story to anabolic steroids. So, you know, due to optics, due to this stigma, the medical community just hasn't focused on it. They, you know, in medical school, they just don't go over it. It's, you know, they're kind of considered
strictly for the use of bodybuilders to get jacked and has no other
right,
benefit
yeah.
to it.
And that didn't help either, right? So the bodybuilding community really took to this, and in the bodybuilding community, some people were having problems, and this further stigmatized it. Like, there wasn't a distinction between the abusive doses used in the bodybuilding world and therapeutic doses. And that just hasn't been made. And it still hasn't been made. There's a lot of the studies that just kind of like coalesce both of these concepts and say, well, because this, you know, and then the people who were coming to the doctors, the bodybuilders who were taking abusive doses for decades, and then they came to the medical community. The medical community would then say, hey, look at this guy. He's got heart problems and all these other issues. And it was because he was using these steroids. But it's not, the distinction isn't made. Well, yeah, he was abusing them for 2 decades. And that's, I mean, you know, so, you know, this is why the medical community, the optics have been bad, you know, and, you know, for that reason, they just haven't focused on this, right? The medical community does a lot of things well. In this specific field, the focus hasn't been there. The education hasn't been there. They don't learn much about it in medical school. So it's just not part of their forte.
Could also be because nobody has the patent on it anymore. So because they can't promote it as a drug that the big pharma is going to make some money off of, they kind of throw it under the bus.
Right. So what we learn too is when you have very large stigmas and movements, it's caused by more than one reason, right? It's not this simple, okay, here's the reason, bang. Because if it was that simple, it would be easy to destigmatize. So it's actually a coalescing of several, you know, myriad of factors, some of them we're not even thinking of, that come together. And you're right, that's another one. Like the drug companies have no use for it anymore because the patents are all up and they can be compounded, right? There's a lot of factors that come into it. But yeah, so for me, for somebody like me, I've had kind of like a bird's eye view, right? I've just amassed this massive amount of data, empirical data that I've seen more than just about anybody else in the entire country. I've just seen it on a level that nobody else could have unless they had my background. And so you know, one of the things that I can see is, you know, going from the bodybuilding community to the therapeutic community. You know, like I'm all about health and safety now, and I understand. But one of the things that is just not understood, and because everybody's scared of these compounds, the medical community, you know, with the lack of education, they just really warn about you know, these compounds, and people are afraid to use them. They're afraid of doses. They're afraid, you know, if people were afraid of ibuprofen, right? And we said, you have a headache, and we say, well, here, take 10 milligrams, right? What's that going to do? Well, nothing, right? You're just going to say, well, this didn't really do anything. I still have a headache. Yeah, it didn't work because you're not taking enough, right? And so they're not understood enough, and a lot of people are just afraid, and they're not to be afraid of. So me, again, with my background, I have seen such a vast, wide berth of doses being taken by people. And yes, abusive doses are bad, but I've also seen thousands of people using abusive doses for a very long time. And it's not good, and I would never recommend that. But also, you know, there's still a wide berth of dosing that we can use that is safe, that is healthy. And it's more than what the current, you know, a lot of the current, you know, it's more than this 100 milligrams a week, or, you know, even 200 milligrams a week is not enough for a lot of people. It is for some people, but not for a lot of people. Okay. And that's what's not, you know, that's what a lot of people are doing wrong. We're just kind of coming in and underdosing people, not understanding that I've just seen this on a level where I understand where it starts to get bad and when it's still very safe and is very fine. And we shouldn't be afraid of these compounds. They're very beneficial.
So why don't we talk about a few of these? Probably the most commonly used one would be, I would assume, Nandrolone. I've seen a lot of the TRT clinics in the US using Nandrolone. I'd say second to that would maybe be something like Oxandrolone. A couple of them might be using growth hormone, the secretagogues. But I'd say of all the TRT add-ons, if you want to call it an add-on, the one I see the most commonly prescribed is Nandrolone. So when do you incorporate Nandrolone with a typical patient or client?
Sure. So most of these derivatives, especially the one we're going to go over, so let's get to why we use them. I kind of forgot to go over that.
If you want to touch on that first, why we use them before we actually explore them, by all means.
Yeah. So why we use them is a lot of people. So testosterone is purely beneficial, right? Even as we move up in dose, testosterone itself is beneficial. What causes the problems is the upstream and downstream hormones that testosterone either converts into or prevents from being produced in the body, right? This is where the problems come from. So if we're using testosterone and people start having adverse side effects from the conversion into estrogen, which is the most common, the common reasons for an adverse reaction, we can utilize these derivatives, especially many of them do not convert into any type of estrogen or estradiol. And we can use these to mitigate estrogenic side effects. And in the case of Nandrolone, we can also use it to mitigate DHT side effects, since Nandrolone does not convert into DHT either. So in essence, what's surprising is that the medical community, what they don't understand is that these compounds, not only are they safe to use, they help reduce the potential for adverse side effects, right? So, so I guess now getting to Nandrolone, what can we do? First, let's go over a couple of the stigmas from Nandrolone. Or maybe we can do Nandrolone first. The reason we'd use it is because it doesn't convert to estrogen, it doesn't convert to DHT. So if anybody's having any of those side effects, and additionally, because Nandrolone is an injectable, and it does, so therefore it bypasses filtration by the kidney or anything. It's not hepatotoxic. It's not nephrotoxic. So it can be taken long term. There's long term with testosterone.
Some people do suspect that there is a certain degree of neurotoxicity though with Nandrolone.
They do, and I have read that as well. So, but the idea is also that, and what these same studies show is that when it's blended properly with testosterone, the testosterone's conversion into estradiol does have that neuroprotective nature, and will prevent Nandrolone from being at all neurotoxic. So that's why it has to be blended with testosterone. So now let's get on to the stigma of Nandrolone, right? So Nandrolone has this big, you can read it all over the place, Deca Dick, right? Deca Dick became popular back in the probably 80s and 90s, early 2000s because, believe it or not, and a lot of the younger people wouldn't know this, but anabolic steroids used to be really hard to get. It was hard to find them. They were very expensive. And people would just take whatever they could get their hands on because it was difficult. So there was a lot of just Nandrolone going around, and people would get it and take it. When you take Nandrolone by itself, it shuts down your endogenous supply of testosterone, right? And it does not convert to estrogen. Or it converts to little or no estrogen. There's some conjecture on exactly what it converts to and how much, but testosterone is the only. The conversion of testosterone through the aromatase enzyme is the only male's only source of estrogen. So when we have no testosterone in our body, we get no estrogen, no estradiol, and that leads to so when our estrogen is low, the common side effects, ironically, are the same as high estrogen and the same as low testosterone, are libido issues, fatigue and lethargy, anxiety, and just the general sense of not feeling very well, right? And so we can get all of that, and especially the erectile dysfunction, with just using Nandrolone alone. And this is where the myth and the legend of Deca Dick grew, right? From people using Nandrolone only because that's all they could get their hands on back in the back in the 90s and early 2000s, late 80s. When properly blended with, so now let's come to me. Like, what have I seen? Because I've seen thousands and thousands of people. I've guided them through the use of testosterone and nandrolone, and I don't have any problems. There's no problems with Deca. I don't have, I don't have problems with anybody having, fatigue or some kind of sense of anxiety from it. I only have positive. Plus additionally, nandrolone's notorious for reducing joint pain. So now we have a case where it's more systemically anti-inflammatory than testosterone, right? There is evidence that it does increase the production of synovial fluid. So it's great for joint and tendon pain, and it's absolutely notorious for this. In their heads, they think that it does create that, right? So I'll have people who say, yeah, I was on 600 milligrams of testosterone and 300 milligrams of nandrolone, and I had erectile dysfunction. It was the Deca. Well, you were also on 600 milligrams of testosterone, and that will cause erectile dysfunction for a lot of people. And so it's not, you weren't having a Deca problem, you were having a too much estrogen dick problem, right? And that's, so there's been a lot of lack of understanding and lack of too much listening to a lot of the antiquated notions and dogma. When we properly blend testosterone with nandrolone, I have nothing but beneficial results, on the order of thousands and thousands of people, and I've seen it.
So I'm wondering if it's just the way, you brought up pathways earlier, that in any given individual, a certain compound might be more prone to go towards one pathway than the other pathway. And we talked about this offline a little bit before the video. I'll bring it up. Mm-hmm. That I did videos about my nandrolone experience where I was jacking it up just to see if I would gain some mass. And I ended up getting like really bad anxiety, but I said, okay, well, clearly I didn't tolerate high levels of nandrolone the way I did. And maybe if I would have just kept it lower, it would have been better. And in my case, I did end up getting a little bit of libido issues and erectile dysfunction issues, even though my testosterone dose was very, very, very good. And on that testosterone dose, I never had issues before. We know that it doesn't convert into estrogen, but we know that in some men, it can jack up prolactin a little bit, or can jack up progesterone a little bit. And perhaps it just happened to be by sheer coincidence that my prolactin and progesterone levels, I haven't done labs in ages at this point, but maybe they were a little bit higher than they should have been. And then by adding some nandrolone over and above, well, now they got up higher enough, just to the point, and high enough because my body is made in such a way that the pathway sense winds up converting more to those things, that it was then mitigating the benefits I was getting with the testosterone. And so what I did was, even though my testosterone dose is quite high as it is, I said, okay, I have the symptoms of low testosterone. Let me now raise testosterone levels even further, because I have symptoms of low testosterone. I don't care what the dose is. I don't care what my serum levels are. I have symptoms of low testosterone. So I brought my testosterone levels up. Lo and behold, I started feeling better. That amount was mitigating the issues I was having from the higher, maybe potentially higher prolactin and higher progesterone. Then I started throwing in some P5P to see if I can bring that down. I started bringing that down. Lo and behold, now I start having symptoms of high testosterone again, just feeling worked up. I can't sleep. I'm stressed. I feel aggressive. And then I wound up having to bring it down. So it seems to me that everybody can have some kind of an issue that will affect why it is that a given dose or given serum level doesn't work. They may have issues why certain compounds works great for them, and why maybe it doesn't. Maybe for the vast majority of guys, it tends to follow more towards a certain pathway, and they take it, they feel good. I absolutely did have the joint relief within a week. Within a week, I remember getting up out of bed. I'm like, I just feel so much less stiff, so much left. Not that I was achy and stiff, but I just felt more elastic and more loose and whatever else. But I'm just kind of wired that way. So I'm one of those types that I just react badly to everything. It is what it is. But most of the guys I talk to on Nandrolone, the vast majority of the guys I talk to on Nandrolone, they've only seen benefits pretty much with doses like between 50 to 100 milligrams a week, not more, along with a decent TRT protocol. You did mention about estrogenic symptoms, and I'm sure all the people that have been following my videos, they're going to say, okay, Danny's going to lose his shit about that. In my experience, the guys that were having their symptoms of what they were calling estrogenic symptoms, it always seemed to be the same types of issues. Either A, they weren't taking enough testosterone, and upon raising those levels, those issues went away. And what's funny is that the resultant estradiol wound up rising as well, along with their higher dose of testosterone. Meanwhile, they felt better. I've seen people where their dose was too high, and they said they had estrogenic symptoms, but maybe it was just the fact that they had an issue where they just could not tolerate that amount of androgens. And I've had a lot of guys that report estrogenic symptoms where they, I'll ask them, what are they doing? And the dose is good, serum levels look half decent, whatever else. Not that I really put any weight in labs and serum levels at this point, but they were doing maybe once a week injections or twice a week, and they had single digit SHBG, or maybe SHBG below 20, and they're doing twice weekly. I would tell them, can you try to split up your dose a little bit more? And they would, and the issue would go away. And I said, well, we haven't touched estradiol. You can go look at your estradiol numbers. They're pretty much going to be where they were before. If anything, you can potentially even try raising your dose more. They would raise their dose even more. Their estradiol levels would go up even more. And then meanwhile, they still don't have that issue, only because it was, for them, it was an issue of their hormones kind of peaking and dropping throughout the week. And by increasing the frequency, that seemed to level them out, and it made them feel a little bit more flat, a little bit more stable, and then their issues have resolved. Now, I do encounter some guys from time to time, but they're few and far between, where you look at their dose, you look at their serum level, you look at the frequency of administration, and you say, this guy's doing everything that I would already recommend. Is it just possible that his body was already maybe very estrogenic, meaning stuff in his environment, cosmetics, body washes, shampoos? I've gone through this a lot, how our skin is kind of it absorbs everything it touches. Could be something in the water. It could be something with maybe some kind of a medication he's taking. It could be, and he's living in a very polluted environment. Maybe he drinks a lot of alcohol and his liver function isn't that great. That's where most estrogens get metabolized. So is it possible that he was already a little bit estrogenic, and now that he's on TRT and raising his dose, he's raising now his estradiol, and now that he's just become very, very, very estrogenic because his estrogenic load in general has gone up, and by potentially incorporating compounds like this, it mitigates that, and that's why they feel better. So I'll ask you straight out, because a lot of people are probably asking, do you ever incorporate the use of aromatase inhibitors with patients, or do you typically prefer to use compounds to say, let me at least get levels to a certain point where you feel good? Perhaps you are having some issues with some kind of estrogenic load. Let's incorporate these other compounds to minimize that as much as possible without necessarily just giving them milligrams a week of aromatase inhibitors. No.
Yeah, aromatase inhibitors are bad. So there's a lot to unpack there, but let me start from the very beginning of where you started. So the number one thing to understand, and this is exactly what you said, is that everybody is different and people are vastly different. And it's really important to understand that. Now, I don't want to say a lot of people, but there's some people who speak, especially if you go on the forums and you start reading things like, Reddit or other forums, who can't see outside their own geocentricity, right? They can't see outside what they've experienced or a couple of their gym buddies have experienced. And so they say that is law. If this happened, then this is law, and this is what everybody should feel. And everybody should be able to do this because I did it and it worked, right? And when you start aggregating the massive level of empirical data that I have, you start to realize just how different everybody is. So you're absolutely correct in saying that it's really this coalescence of a massive amount of things coming together. And, kind of like what you're very good at, and which is why you're good at this, is troubleshooting. Is this, we got to start taking things one at a time and troubleshooting. Now, moving on to estrogen, the first thing I want to say is that the amount of problems are very small. Okay, so 95% of the people get on TRT and run with it and are great and are fine. right? 95%. So we're talking about a small subset has problems, right? A very small subset, about 5%.
And what's funny is those 95% aren't in the Facebook groups and on the forums and on the stuff complaining. We're seeing the 5% that didn't work for them.
So exactly. So when we're on Reddit, when we're on the Facebook groups, we're not seeing an accurate representation of a real sample set of society. They're forums for people to come with problems, right? So it's a subset, an anomalous subset of people who have problems. So you have to understand what you're reading. You're reading, like I said, a subset of people that are anomalies that come and have these problems, because just like you just said, people don't take TRT, dramatically improve their quality of life, and then worry about coming back to Reddit just to go, hey, everything's great, see you later. It's, so we're just reading all the horror stories, and that's all you see. And then you start, and I've seen Reddit and these groups like scare so many people, and I get people coming to me terrified to try any kind of real dosing or
because they think it's the norm. They think you're going to get on TRT, they're going to have the same issues as these guys.
That's correct.
Yeah.
So we're only talking about 5% of the people, right? So in this 5%, in this small subset, when I have a problem, the first thing I do check is estrogen. It's just, even though it's still not typically a problem, it seems to be the first place, and it's the easiest thing for us to look at, right? So I do try that, and you are correct. A lot of times it's not that. And a lot of times it has to do with underdosing, or it has to do with, and sometimes it has to do with prolactin. Sometimes it has to do with progesterone. So what I like to say is that I have to, for everybody, I have to get all of their hormones into this Goldilocks zone, right? Where everything's just right. And some people have broad Goldilocks zones, and some people have more narrow Goldilocks zones, right? So most people, the 95%, just can take TRT. Everything resolves into their Goldilocks zones, and they're off and running, and they're good, and see you later. But sometimes these people with narrow Goldilocks zones, if one thing gets out, it can throw off their whole quality of treatment. Mm-hmm. And we just got to find out what it is, right? And so, to answer your question, no, I don't like aromatase inhibitors. We'll adjust the protocol in other ways to if estrogen is the problem, which it is. And a lot of times it's like, I'm taking HCG, and I don't feel good. Well, HCG spikes estrogen to a massive level, right? So as much as people evangelize the use of HCG when you go online, from my bird's eye view, what I see in this massive aggregate is HCG causes more problems than solutions.
I'm kind of seeing a 50-50 on my end.
Yeah, right.
I'm pretty much equal. Guys are saying, I take it, it's fantastic, it's amazing, better erections, better sensitivity. Yeah. I was anticlimactic before, now that's no longer an issue. So other guys take it, kills their libido, kills their erections, break out an acne. Yep. I tried it again recently. It just does not. No.
For the symptom magnet,
I would expect that. Yeah.
I would expect that. I see a little bit more problems in HCG than I see solutions. So it goes a little bit more than 50-50. But you're right. You're absolutely right. For some people, it was the magic bullet, right? It somehow it cured everything. Somehow it. There's theories that it brings progesterone into level. It allows for some of the downstream hormones to be produced. So a lot of what I do is, although I understand the science and I know the science, there's a distinction between what the scientific theory says and what actually happens, what we actually see in the field. And there's a big distinction there. And I know the scientific theories, but I've also seen everything. And some of it, the empirical data, what we see in the field is more important than what the scientific theories say, right? So, I just have the benefit of seeing that on a massive level. Did I answer the question?
Yeah, so I threw a lot of questions at you.
Yeah,
so you answered a lot of them.
I think we went off, but I think I got to it. Yeah.
So let's then talk about. I mean, you spoke a bit about the stigma behind Nandrolone, but when would you incorporate Nandrolone? Can you give me a typical example of, here's a patient that has such and such issues. This is a primary case where I would implement Nandrolone at, a given dose to get a specific outcome. What would that be?
Okay. So that's a great question. The number one reason that I incorporate Nandrolone is for joint pain. Like, people have joint pain. It notoriously reduces joint pain. Never had anybody say that I didn't notice any reduction in joint pain. Never. And we're talking thousands and thousands of people.
Yeah.
So that's the number one reason we'd incorporate it. So another reason to incorporate it, okay, as we've talked about, part of what the sense of well-being that we get from these treatments, right, is the anabolic nature of the compound, right? It does so many different things as far as hypertrophying muscle cells, increases. It takes a lot of energy to build muscle. It takes a lot of energy to maintain that muscle mass. So our metabolisms are increased. I was watching the podcast you did with the doctor on using anabolic treatments, using anabolic to treat disease. Yeah.
Right.
And, and he was even indicating, which I didn't quite realize until I watched that it actually increases the amount of insulin or glucose that is pushed into muscle cells. Right. So it really helps reduce, reduces people insulin, which we all knew that. We know that it really helps type 2 diabetes. Right. But I didn't know exactly why. And it makes sense when he explains it. But so yeah, the anabolic nature of these compounds is and so now what the anabolic nature also does is it increases our physique, makes us look better, right? It gives us aesthetic value. It also, these anabolic compounds control the distribution of our body fat. So now when we're low in a catabolic state, our body will actually burn its own muscle mass before it burns your fat stores. It's an evolutionary mechanism. When you're sedentary, your testosterone goes down, and now your body, since you're not using your muscles, your body burns your muscles first and saves your fat for the last source of energy. When we're in an anabolic state, when our testosterone levels are high or whatever anabolic compound we're using, our body switches to using our fat stores as one of our primary sources of energy. Still uses the glucose in our blood, but fat stores become primary over using our own muscle as energy, right? So it also controls the redistribution of fat. So now the fat goes from the trouble areas, which people usually accumulate, people with low testosterone usually accumulate in their abdomen or wherever your trouble area is, whether it's your thighs or your ass or whatever. It redistributes out into what we call the epimysium fat, right? Which is the outer lining of your muscles. So now that your muscles can pull from energy when it needs it from the outer lining of your muscles. This is more aesthetic as well, because now your fat is away from your abdomen. It looks more aesthetic when it's redistributed. So these aesthetic values, we are also creatures of that take on social cues so we notice things like people doing a double take at us when we look good, right? When we've been in the gym, when the treatments that we're using, the anabolic treatments that we're using are really working to do all these things I just said, and people do a double take at us, people compliment us, people say, hey, you really look good today. When the guys are respecting you because you're just, you're just looking more stout than normal, and you can just tell, you take on these very subtle social cues to notice that people are kind of a little bit more in awe of you. And these things make us feel good, right? These really raise the dose response, or the dopamine, oxytocin, serotonin, endorphins. This is almost half of what makes us feel good when we do these, when we go on these treatments, right? I mean, testosterone is dopaminergic in and of itself, but it's also dopaminergic in, the oxytocin, serotonin, endorphins. The way that our social lives change, because now we're more motivated to get to the gym. We're motivated to eat better. We have more energy to go do things with our families and to better support our families and all these things. It's just a positive reinforcing cycle. This is almost half of what makes us feel so good when we're on these compounds. And people don't realize that that's a part of it. So now when we have somebody, right, who is having adverse side effects from taking a 200 milligrams, just for instance, a 200 milligram per milliliter dose, and you hear especially people on Reddit going and just evangelizing these really small doses. I take 60 milligrams and that's where I feel good. So therefore, again, they can't see outside their own geocentricity. Therefore, everybody should only be taking 60 milligrams a week because that's where I feel good. So everybody else should be doing that too. And that's just not rooted in any kind of reality because most people do not feel good at that level, even 100 milligrams per week. And most people feel better on more.
And just as at the other end of the spectrum, like me, that under 250 a week, my symptoms all come back. My sweet spot is somewhere between 250 and 300. I tend to stay more around 300. For 300, for a lot of guys, 300 is a steroid cycle. They'll put on like crazy amount of money on 300. So they're like, you're on a steroid cycle because if I take that much, I'd be, if you would take that much. If I take this much, it's just TRT for me.
Yeah. Right.
A steroid cycle for me would probably have to be 600 milligrams and up in order to really say like, holy cow, I'm growing like a weed. It's just the way I'm built for whatever reason.
Yeah. Again, back to everybody's different. And I've seen that plenty of times before where people, some people need 400. Or more to feel their best.
Yeah.
So again, if you're one of those people, right, who you take 200, you don't feel good, you don't feel right, you get down to 80 milligrams and all of a sudden you're like, this is my sweet spot, right? Because this is where I feel good. I don't have the adverse side effects. Well, you're missing out on part of the anabolism I was just talking about, right? You're not feeling your optimal because people just don't feel they're optimal at that level. So what you can do in that case, instead of find out where you do best on testosterone, and then just add that in Nandrolone, right? So now you're doing good on 80 milligrams of testosterone. Well, throw on 80 milligrams of Nandrolone. You'll also have that the added anabolism from the Nandrolone, which which further resolves symptoms of hypogonadism, and gives you all the effects that I just talked about without any adverse side effects. And this is another case where we'd use that when somebody's just not doing well on any more than 100 milligrams or 80 milligrams of testosterone. Let's add Nandrolone or Oxandrolone, which we can talk about next. And Oxandrolone is another good one. So I guess we can move on to Oxandrolone.
Yeah, absolutely.
Those are the times I would use that. But Oxandrolone is also another, amazing derivative. Oxandrolone especially, and Methenolone as well. I've guided thousands of people through these, and I have never had anybody come back to me who's taken Oxandrolone and said, "Take me off that Oxandrolone. I don't like it." Never, not once, ever. Nobody has any. Like, I've never seen adverse reactions on those compounds. So it's like, again, in this case, if we were just looking to really start fine tuning, if maybe somebody's taking testosterone and they're having a little too much water retention, they don't okay, well, we can reduce your testosterone and add some Oxandrolone. I mean, and everybody who takes it is just like, wow, this is great. I feel better. I look better. Oxandrolone is just an amazing compound for that. Now, so some of the stigma that comes along with Oxandrolone is it's only for burn victims, right? Or it's a DHT derivative, so it's got to make you lose your hair, right? So Oxandrolone, there is evidence that shows that Oxandrolone increases collagen synthesis, so it would be good for burn victims. It's also good for people who are coming off of surgery, tendon surgeries or ligament surgeries. It really helps the collagen synthesis there. But as an off-label use for using it to really mitigate side effects people are having from testosterone, or really being able to fine-tune and dial in a protocol, I mean, there's almost nothing better. The only problem with that Oxandrolone is that because it is C17 alkylated, it survives digestion, but it is filtered out by the kidneys. So it is a little nephrotoxic and hepatotoxic. So it's not a good idea to stay on it for long periods of time. But, but certainly the use can really start for a temporary time, help further resolve symptoms of hypogonadism.
Okay. I've seen some guys incorporating very, very small doses, even as low as like 5 milligrams and getting benefits.
Right.
And I think they argue like at such a tiny dose, it probably won't really have much detrimental effect on liver values or anything else. Other people disagree. Mm-hmm. And others will just use it for a short time just to kind of drastically alter their body composition. And then once that's been achieved, they're able to maintain it with their TRT and exercise and diet and whatever else. Mm-hmm. Has that been your experience as well?
Yes. Yeah. So, yes, I would agree that, because Oxandrolone is, more mildly anabolic, mildly androgenic, than testosterone, or one of the more mild, of the orals, right? It's not as toxic as some of the other ones, like, oxymetholone or methandrostanolone. So it's not as toxic, right? So small doses certainly could be handled. And so what you're talking about is some people disagree that no, even that amount's toxic. Well, what have we seen in the field? And I've seen in the field that no, it doesn't really affect liver or kidney values when you take it at small doses. And that's absolutely correct. It doesn't matter what you think, what the science says. It matters what actually happens. And we don't see it affecting liver or kidney values in small doses. In higher doses, it just moderately affects these. And another stigma about Oxandrolone is that stanozolol is that it affects cholesterol, right? What do we see in the field? Not as much as people say that it does. Some people aren't really affected. Their cholesterol isn't really affected at all, and some people it's just moderately affected. I've never seen any cholesterol levels get wildly out of control because of these doses at these moderate doses.
Right.
Everything changes when we talk about massively abusive doses of all these things.
Okay, so what would be for stanozolol, same type of principle? Would it be more to mitigate people that are higher estrogenic load, whatever it is, mitigate estrogenic symptoms, have a little bit more anabolism? Earlier you were talking about the Nandrolone having the relief on joint pain. With stanozolol, is there a specific benefit where you would use that more so than others, or what type of application? Just to maybe elaborate on that.
Sure. So stanozolol, yes, one of the stigmas is that it causes joint pain. Okay. Now there is some scientific theory that it does inhibit the synovial fibroblasts, right, which would inhibit synovial fluid production. What do we see in the field? Not so much. It does. Some people, it's kind of like there's a small subset of people who do experience joint pain when they take stanozolol, but
they just say it dries out their joints, right?
Very few and far between. Most people do just fine on it, right? So when do we use this? And so stanozolol and oxandrolone are very similar. Stanozolol is a little bit more anabolic than oxandrolone. So another thing I want to clear up about oxandrolone and stanozolol is that people misread it a lot, and they read, and a lot of times they're not clear on exactly what they're reading, but they read that it's actually more anabolic than testosterone, and that's not true. It's not overall. It's not more anabolic than testosterone. It's more anabolic in ratio to its androgenicity, right? So for the level of of how androgenic it is, it's more anabolic than testosterone, right?
Right.
But so the ratio of anabolism to androgenicity is higher with oxandrolone and stanozolol, and even nandrolone too. But overall anabolism, overall anabolic, the testosterone is more anabolic overall than each of those. But again, these other derivatives are anabolic, and they present significantly less side effects than testosterone.
Would you say, would it be safe to say, I've interviewed Victor Black, and his approach is use as much testosterone as you can tolerate, and as long as you resolve your issues, you get your desired outcome with testosterone, stick with that. And that these other compounds would be used if you can't tolerate sufficient testosterone to resolve your issue, then you can add these other compounds. But so for guys that have where testosterone for them is well tolerated, where they can just keep kind of jacking up their dose a given amount, and they're like, yeah, I'm doing great. You don't really see a need to incorporate these things, right?
Yeah, that's correct. Yeah.
Okay.
It's not like nobody who is first coming to me, I would be like, hey, let's just start piling on some of this stuff. Like, why don't we just give you an Nandrolone and an Oxandrolone? It's not like that, right? It's let's make sure there's a need for it first, right?
So your preference is still always going to be testosterone, and that's the one that you're going to prioritize over and then these will be if and only if we're having some issues on the testosterone side.
Yes.
Okay.
Yeah.
Gotcha. If you want to talk about Methenolone, also known as Primo, I know it's not prescribed. There's obviously a huge, underground community that uses it.
Yeah.
Stigma, why, when, how it's used, for what application, why is it maybe preferred over others, just for people that have that question.
Yeah, so Methenolone is a wonderful compound again, and again, same reason as like Oxandrolone. Oxandrolone and Methenolone are similar in that I only have ever seen positive things from them. Nobody ever takes Methenolone and comes back and says, you know what, take me off that was terrible.
Unless it's me.
No,
I don't do well on any of them, but I'm a freak of nature when it comes to this stuff. Yeah,
except for the side effect magnet.
Yeah.
So, but it's so beneficial and presents almost no side effects. Same with Oxandrolone. Like I have yet to see somebody come back and just say, oh yeah. The only thing I've seen with Oxandrolone is, and I skipped over this, Oxandrolone stanozolol, right, is people think that because it's a DHT derivative that it increases the hair loss, right? So some people who are prone to hair loss, they think that they shouldn't take it, and in some cases they shouldn't, right? Again, everybody's different in how they react to this, but Oxandrolone and stanozolol are both, they're DHT derivatives that are less binding affinity to the peripheral androgen receptors at the hair follicles than DHT itself, right? Okay. So there's a lower binding affinity, right? Even though it's a DHT derivative, it's a lower binding affinity than DHT. So it shouldn't, the science says that it shouldn't cause the hair loss that testosterone does, or the actual DHT does. Do I have people who say that, they shed faster when they take these than testosterone by itself? I do have that sometimes, and it's rare, but I do have people that say, no, when I take Oxandrolone and stanozolol, I notice more hair loss than when I'm just on testosterone alone. So again, in the field, we see different things than the science says, but that's rare. It's rare. Most people tolerate those, and the hair loss is not really an issue any more than testosterone. Certainly not more than testosterone would be, and it's less of an issue with these derivatives. And that's, there's another reason to use the derivatives, to mitigate DHT side effects.
Okay. Now, can with the Nandrolone, you were talking about, if a guy's got joint pain, I'll incorporate Nandrolone because obviously it's going to help the joints significantly, right? Now, can you give me some examples of, a certain situation where you say, in this case, I would use Oxandrolone because of this, or I would use stanozolol, or I would use Methenolone, or I would use, how do you determine which of these you would use? Can you give me some examples and then say, in this particular circumstance with this particular guy, I would go more towards stanozolol than Oxandrolone because stanozolol is more prone to do this or whatever else, just to kind of have for guys asking a little bit more details of what the actual action that they have. Mm-hmm. Or is it more a question of, let me try you a little bit of Oxandrolone, and if you don't tolerate, then we can try maybe some stanozolol instead because they're similar. We'll see which one you tolerate better, which one is it more a question of that than?
Yeah, there's a few things that go into it. And one of them is, the exact circumstances. The incorporating Nandrolone is more of a long-term solution because we can take that indefinitely with testosterone. The other ones we can't really take indefinitely, right? So are we looking for a permanent solution? to something, right? So in that case, we would just use Nandrolone.
And can I just ask why? What is the reason why you can't take them indefinitely? Let's say even just at a low dose. If someone's incorporating, say, they're taking, just use Methenolone as an example. They're taking a measly 100 milligrams a week, and they say 100 milligrams a week, I feel good, and it's changing my body composition.
Yeah, Methenolone you could use indefinitely. Yeah, that's why, and so back to Methenolone, the fact that it isn't incorporated often into United States TRT protocols is just proves the lack of understanding and knowledge that, the medical community, because that their focus has been off, right? It's been off on other things. If there was any kind of studies and focus on, well, what could we use with testosterone besides testosterone to make people less prone to side effects, it would unequivocally be Methenolone. There's almost no side effects that come along with it. And right, so that is another one that we could, I didn't say that because nobody has it in the United States. No pharmacists have it in the United States. So, but that would be one that if we did, I would definitely utilize that all the time. It's a very good one to use indefinitely with or without testosterone. So there's a to kind of go into to answer your question some more, there's the idea that a lot of these derivatives do not, one of the reasons that we use them, they do not convert to estrogen. So the use them by themselves would reduce the estrogen, and then there might be some neurotoxicity because of our low estrogen, right? When people have low estrogen, there's symptoms. There's symptoms to that, right? There's, fatigue, some anxiety, erectile dysfunction. They feel anxiety. They just don't feel it. They don't have a very good sense of well-being. When people, when in the past, when I've had somebody with very sensitive to estrogen go on Oxandrolone only protocols or Methenolone only protocols, you can't do this with Nandrolone, but with those, they do very well. Like nobody has problems with that. Like everything is fine. Like as far as sense of well-being, that people have been doing this for decades, and there's no, more than that, for 50 years. And there's been no adverse side effects from some of these compounds being used in lieu of testosterone. That means, Primobolan by itself, Oxandrolone by itself, Stanozolol by itself, they never seem to cause any of these problems. There doesn't seem to be any neurotoxicity. So, I always recommend a testosterone base for everything. However, the fact is that there are some cases of somebody who's very sensitive to estrogen, which does happen sometimes, where it just makes sense to put them on an Oxandrolone only. And they do very well, feel great. Like they've never felt before because nobody's ever tried to put them on anything except for some level of testosterone. Right.
So you're saying for someone who's getting what you would refer to as estrogenic symptoms, you would lean more towards Oxandrolone than Stanozolol.
Oh, so that would come up. So another thing I have learned to incorporate over time, right? And this is, I used to make a mistake a lot of times of telling people exactly what I think they should take because I'm experienced, I'm the professional, and I know how to get you to where you want to be, right? What I've learned is a big part of these treatment protocols are people's psyche, right? So people can, if I'm guiding somebody through something that they don't believe they should be taking because they've done research to the contrary, or they have, or they think that they just want to do this because they've read about it, or their buddy did really well on this one thing and they think they should be taking that. If I don't at least listen and kind of try to work with them, then people will psych themselves out, and people will start finding symptoms that either don't exist or that are actually very mild, and they'll make them a bigger deal than they are, because a big part of this is psyche. Like whenever anybody listens to me, I can always get them to where they need to be. I've become very adept at, sometimes it takes me some time, but I can dial everybody in and I know how to do it. Where I do have problems is when people psych themselves out, when they start freaking out and they just stop their protocol or change something because, just without telling me, because they I don't know, in their own head, something's going wrong. And that's where people fail when they psych themselves out. So to answer your question, when it comes time to, okay, it's time to use a derivative like oxandrolone and stanozolol. Stanozolol, like I said, is a little more anabolic than oxandrolone. So it kind of comes to a preference at that point. They're both very similar. If this person says, I've read more about stanozolol, I want to use that, my buddy did really well on it, I think I should be using that. Okay. All right, then it's fine. You know, they're very similar. They both have the same effect, and they're both going to, according to this. So then it might come down to preference in that case. I don't think there would be.
Let's see if we removed preference out of the equation, because I can understand someone comes in like, I read really bad things about such and such. I really want to try that. You're like, all right, well, let's give it a try. I mean, they're all kind of similar to a certain degree. They're all going to kind of do similar things to a certain degree. If you've got this one preference and you're going to be more comfortable with that one, then go. And I get that. Mm-hmm. But say, for example, you got a guy coming in, he doesn't even know what any of these things are. Mm-hmm. What would be a given situation where you're doing an assessment and you're like, okay, now for this guy, I'm going to use oxandrolone, but this other guy, I'm going to recommend stanozolol. Like, is there a specific reason you would use one more than the other, or is it just really down to the client's preference?
Yeah, in that case, that they're similar enough to where it would come down to the client's preference. I don't think I would probably just pick. I would probably just pick oxandrolone just because. There's no instances of it ever causing any adverse side effects, in my experience. And stanozolol, every once in a while, you do get that joint pain, but rarely. And the only other reason you'd use stanozolol over oxandrolone is because it's more anabolic. And if you needed more anabolism, then you would use stanozolol over oxandrolone. That would probably be the only reason.
Gotcha. Or they try the oxandrolone and they're like, I'm not feeling good. Okay, well, let's get off this. Let's try the stanozolol instead. Like, oh, I feel good now. Okay, great.
Yeah,
you didn't tolerate that one. You tolerate this one better. Yes. Fantastic. We're done, type of thing. Okay.
Yes.
Okay.
Yep.
So your clinic, therefore, hormonesforme.com. I've sent a lot of guys your way. You're getting a lot of really positive. Probably more positive reviews from you than pretty much anyone else I've sent. I can say that very, very, very honestly. Mm-hmm. I do visit Reddit from time to time, and there's a lot of positive testimonials from guys how you and your team has kind of helped.
Yeah.
So how is it that you know, and again, you might say this is kind of proprietary information or this is a big secret and I don't want to give away my secret sauce type of thing, but how is it that you're able to prescribe a lot of these different compounds, again, with the exception of Methenolone because it's not used, but the Nandrolone, Oxandrolone, Stanozolol, how are you able to get away with prescribing this when a lot of the other clinics say, oh, no, we can't, it's, it's just not allowed or whatever the reason?
Yeah, so we do have a legal team. I also have learned a lot of done a lot of legal work in my day, and I have piled myself through all the statutes. So there is recommended reasons for using these compounds, but there's also a lot of leeway for a physician to prescribe, especially if we're using this, to mitigate a side effect of testosterone, right? And that's a perfectly rational and reasonable reason to use it. This person doesn't do as well on this, so we're going to, prescribe this to augment and improve the way that he responds to this treatment protocol.
So there's nothing in the law and then in the health, the medical boards or whatever else, the FDA, whatever, that really restricts anyone from using it. You've just looked into the laws and realized as long as you're saying I'm using it for a specific reason, a legit, genuine reason, they can't really say no. They can't give you a hard time.
Correct. Yeah, that's correct. I mean, just so we're not, we can't prescribe to enhance physical to. For physical reasons, for bodybuilding purposes, for performance enhancement, like we can't for that. We're prescribing to reduce symptoms of hypogonadism, right?
Gotcha.
So as long as we're doing that, where, and they're not responding as well to testosterone. So to further reduce these symptoms of hypogonadism, we're prescribing this derivative because it presents less side effects than the testosterone.
Gotcha.
It comes down. So why aren't other clinics doing this? And it comes down to the stigma again. The medical community is run very prominently on optics, right? And a lot of the physicians, they just don't want to even be seen as one of those clinics that's that's just seen in a negative light. And these derivatives have been seen in a negative light, and there's nothing negative about them. Like as we've seen, they're incredibly helpful. As with the doctor that was using anabolic steroids to reduce disease, we've seen that they do amazing things, and they do. And I've seen it for decades. I've seen, and just not only testosterone, but blending some of these do amazing things for people. They really improve quality of life, and they really help people, reduce diabetic symptoms, reduce their fat content. Most everybody. I have so many people who are able to get off depression meds, pain meds. This includes opiates. They're able to get off their insulin, medications, and depression medications. I see it all the time. Oh, and blood pressure medications, right? Like I have people come in, they're on blood pressure medications, and then pretty soon they have to drop it because their blood pressure dropping too low. We're reducing the amount of overall medications and people's we're increasing everybody's overall health, and the derivatives are a part of that.
Gotcha. So guys, Ryan Root, www.hormonesforme.com. I got the link here under the video. Ryan, on the past video, you said if anyone mentioned the Danny Bossa podcast, you'd kind of provide some form of a discount. Is that still the case? Or
yes, I have been. People have come in. And again, I want to thank you, Danny. You've really, not only with how you and I work together, but how the information that you provide, like especially these videos that you've been coming out with are very informative. I learned a lot from all the videos I watched from you. So awesome. I really appreciate it. You do a really good thing. You really, benefit a lot of people. And then, I appreciate it a lot. So the people who do come and mention that they saw me the Danny Bossa, I have been giving them a discount.
Awesome. Okay. And I know your prices are already like pretty much the lowest around. And a lot of guys, especially on Reddit, they've been, I pop into threads every now and then that where your clinic's being brought up, and they're basically saying this is the cheapest place around, best service around, best customer service around. You can pretty much get anything there. So that's been a big thing. So obviously I'm sure the discount is there's only so much discount you can give on an already extremely aggressive competitive price there. But as long as people know that, I'll continue to refer. Guys, if any of you have been using Ryan's place, feel free to comment in the down below in the comment section, whether you've had good experiences or even if you've had bad. I'd like to see both, because if I wind up getting dozens of bad reviews, I'm gonna have to call Ryan and straighten them out, everything. But again, so far I must admit I've been getting very, very good, very positive reviews. And also, guys, there's a lot of people watching these videos, but not too many people clicking that subscribe button. I'm a really, really busy guy. Ryan knows that I worked at a work emergency. I worked all night till 5:30 in the mornings. I don't really have a lot of time to even do these videos or then edit them and upload them and whatever else. I don't. As long as I see the subscribers going up, I'll keep putting them out. If I see the subscribers kind of, plateauing off, I might say, I got better things to do. So if you haven't already subscribed, please subscribe and click that notification bell so you get notified. And as long as I see some interest here, I'll keep trying to have guests on like Ryan and different physicians and stuff on varying subjects. So Ryan, thank you again for your time. It's very interesting. I know a lot of people here are, they've kind of pushed the boundaries of their TRT as much as possible, and they're trying to find some like little tweaks and stuff. Or sometimes it's just a matter of, experimenting with different things just to see what effect it has, good or bad.
Yeah.
Sometimes some guys will try something like, oh my God, this was a life changer. So, the more we can learn about it, the better. So thank you again. Thanks for your time.
Thank you, Danny. I really appreciate everything you do.